Okay, good morning and welcome everyone to the first Journal Club of the 2023-2024 academic year. Welcome to our PGY4 residents and welcome back to all of our PGY5s. We start with the land acknowledgement. We recognize that many Indigenous nations have long-standing relationships with the land upon which the work of the University of Toronto's Department of Medicine is conducted. We acknowledge our presence on the traditional territory of many Indigenous nations, including the Mississauga, the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. Today, this land is home to many diverse First Nations, Inuit, and Métis peoples, and we are grateful to have the opportunity to live, work, and gather on these territories. Land acknowledgements are only a starting point for larger conversations. More concrete acts of restitution and transformation are needed to address underlying inequities and blatant discrimination in the distribution of resources between Canada's First peoples and settlers. We have two PGY5 residents presenting today on a common theme, pushing our understanding further on anticoagulation for atrial fibrillation in older adults. First, Dr. Gabriella Jacob to present on the risk of dementia with different oral anticoagulant options. Gabby, please go ahead.
Thanks for the introduction. In the interest of time, I'll just get started, and I don't have any conflicts of interest. The objectives for my talk are to first review the literature with regards to atrial fibrillation and the risk of dementia, to see what the literature has said about the role of anticoagulation in the risk of dementia, look at the current study, provide a critical analysis, and discuss implications for practice. So atrial fibrillation and dementia. The existing literature actually shows that atrial fibrillation has been associated with an approximately 40% increased risk of cognitive impairment. And this was found even after excluding patients with a history of stroke. And the reasons that they think that atrial fibrillation is associated with dementia, aside from a clinical stroke, was found from studies with brain imaging and autopsy studies that have looked at the neuropathological lesions in atrial fibrillation. And they found multiple things, including silent cortical and subcortical infarcts, periventricular white matter lesions and hyperintensities, cerebral microbleeds, a decrease in total cerebral volume, and decreased cerebral perfusion. In terms of anticoagulation, it's hypothesized that anticoagulation should preserve cognition by reducing infarct burden. And in fact, studies have shown that oral anticoagulation is associated with a lower risk of dementia. There's been studies looking at vitamin K antagonists compared to no anticoagulation, showing a 21% lower risk of dementia, and any oral anticoagulant, which would include a novel oral anticoagulant versus no oral anticoagulant, showing a 29% lower risk of dementia. And when they've actually studied patients who are on warfarin and the time in therapeutic range, they found that high time in therapeutic range compared to low time in therapeutic range is associated with a lower risk of dementia. When the non-vitamin K antagonist came onto the market, there were multiple benefits, including a more predictable pharmacology, ease of use as not requiring INR monitoring, and the lower risk of stroke and intracranial hemorrhage. But beyond just these benefits, they started to look at whether there's any benefit to NOACs compared to VKAs for incident dementia. And the literature to date has been mixed. There have been studies showing a lower risk of incident dementia compared to VKAs in a meta-analysis with a hazard ratio of 0.51. There's also been a retrospective cohort study looking at different NOACs showing less incident dementia compared to VKAs, when other studies had actually not demonstrated any statistically significant difference. The limitations of these studies were that there were significant methodological differences, and some of these studies included patients who were already on a prior oral anticoagulant. They had different durations of follow-up, but often were quite short, and the issue of exposure misclassification with an intention to treat approach. So looking at someone who'd been prescribed, let's say, apixaban and then had switched to something else, would still have been classified as having been on apixaban, or if they had stopped apixaban, it would still have been classified as they were on this medication. So When they've looked at novel oral anticoagulants compared to others, looking at apixaban compared to rivaroxaban or dabigatran, they haven't found any differences between them for incident dementia. And none of the trials have looked at edoxaban, as this was newer to the market. That brings us to the current study, which was published in Age and Aging in 2023, looking at the risk of dementia in subjects with atrial fibrillation using non-vitamin K antagonists versus vitamin K antagonists in a Belgian cohort. So they hypothesized that NOACs would have a lower risk of incident dementia compared to VKAs. They took all individuals over the age of 45 who were prescribed an oral anticoagulant between 2013 and 2019. And this was based on 2 of their nationwide databases. They looked at exposure being NOAC users, any of dabigatran, rivaroxaban, apixaban, or edoxaban, compared to VKA, warfarin, or the other 2, which we don't see here, and outcome being incident dementia diagnosis, which was based on an ICD discharge code of dementia or the prescription of anti-dementia drugs. And patients were followed from the time that they were prescribed their oral anticoagulant until the outcome of interest or discontinuation, which was defined as more than 60 days of a gap in their supply of drugs. Or if they switched treatment, passed away, emigrated, or it was the end of the study period. They excluded patients who had a prior diagnosis of dementia or the use of anti-dementia drugs before the oral anticoagulant started. They excluded patients who had a hip or knee replacement or a VTE, as they were getting their anticoagulation for that purpose. Anyone with valvular atrial fibrillation and stage renal disease, having more than 2 prescription claims for different NOACs, or not on an approved NOAC dose for stroke prevention. They did an inverse probability of treatment weighting analysis, which is something that I didn't know about, so I had to read up on. And this is where they actually calculated propensity scores to balance patient characteristics in the exposed and unexposed groups. And then they used the propensity scores to apply weights for each individual and create a pseudo population. So for example, and you can see in this example here, the exposed group has 1 individual with diabetes. And so in patients with diabetes, the chance of being in the exposure group is actually 25% because it's 1 in 4 people. And in order to then balance it, they provided a weight. So this person was weighted and got a weight of 4. And now the pseudo population has 3 additional patients. So there's 4 people with diabetes now, but there's 3 additional patients in the pseudo population with diabetes. And then in the control group, there's now 1 additional person. There's like a third of a person here, and that's 1 additional person in the control arm. So in total, there's 4 patients with diabetes in the control and exposure groups now, as opposed to 3 and 1 prior to this adjustment. And the goal of this is to actually adjust for the confounders and balance them between the exposed and the control groups. So these are the results from their table 1. They had actually over 200,000 patients, and most were getting a NOAC. Just to note that the patients who were receiving NOACs were significantly older than those getting VKAs. And just as well, edoxaban had a shorter duration of follow-up due to it being later to the market. The patients who were receiving NOACs had less valvular heart disease and peripheral artery disease, as well as less anemia. They were more frail, and they were slightly more likely to have had a prior stroke. They also were more likely to be on an antiarrhythmic at baseline and had a higher CHA2DS2-VASc, CAS-BLED, and Charlson comorbidity score. So this is the primary analysis, which was looking at incident dementia for all NOACs versus VKA. And here they found less incident dementia with a NOAC compared to VKA with a hazard ratio of 0.91. And this was statistically significant based on these confidence intervals. As you can see, when they broke it down by the individual NOAC, edoxaban and apixaban were the only 2 that were still statistically significant. When they then did further analysis and they only looked at participants with an ICD-coded hospital discharge diagnosis of atrial fibrillation, they found that the results were more significant, but they were not significant with an intention to treat approach, or after excluding subjects with a new diagnosis of dementia less than 90 days after starting their oral anticoagulant, or having had a prior stroke on the date that they started their anticoagulant. They also did a sub-analysis based on the type of dementia. There was no statistically significant difference when they looked at Alzheimer's disease. And vascular dementia did not have a statistically significant difference, but there was a trend towards benefit within NOAC. For other unspecified dementia, there was actually a statistically significant difference. They then looked at NOACs versus NOACs, and they found that there was less incident dementia with apixaban when compared to rivaroxaban, which had statistically significant confidence intervals there, but again, none of the others showed statistical significance. There was a trend with edoxaban compared to dabigatran or rivaroxaban, but again, not statistically significant. So that brings us to the critical appraisal. So were the two groups similar and recruited from the same population? So in this case, yes, they were both taken from two nationwide databases in Belgium. Were the groups exposures measured similarly to assign people to both exposed and unexposed groups? And I'd say yes, because all patients who received an oral anticoagulant prescription were included, and it was determined whether they were on a NOAC or a VKA. Now, was the exposure measured in a valid and reliable way? This was fairly good, as it was taken directly from the Belgian health insurance database on drug prescription claims. And they actually looked at discontinuation, and they defined that as more than a 60-day gap after the last date of prescription. And they also looked at whether treatment was stopped, and they really followed patients who were receiving treatment and doing an on-treatment analysis, as well as the intention to treat analysis. So were confounding factors identified? So I said partially. They actually included 41 potential confounders. However, they didn't have data on smoking, alcohol use, weight or BMI, or any lab values for renal function or liver function, which would have been helpful and important in this study. Were strategies to deal with confounding factors stated? So in this study, yes, they specifically spoke about the issue of confounders, particularly because the groups were so different. So the vitamin K antagonist group was different to the group on NOACs. And as a result, they specifically did the IPTW analysis to adjust for the confounders. And they also did various sensitivity analyses to see whether that would change the results. So were the groups or participants free of the outcome at the start of the study? So in this case, I would say no, because dementia at baseline was based on ICD codes that were in the hospital, so hospital-based discharge codes or use of anti-dementia drugs. So if participants had not been hospitalized previously or did not get anti-dementia drug, then they would be potentially missed and could have had dementia at the start of the trial. So were the outcomes measured in a valid and reliable way? And again, here the answer is no. So there was no assessment of individuals for the development of dementia. There was no baseline cognitive testing as mentioned. And their diagnosis or outcome was based on a hospital discharge code, which again, if someone had been into an ambulatory care setting, had not received anti-dementia drugs, they would have been misclassified as not having dementia. Was the follow-up time reported insufficient to be long enough for the outcomes to occur? So this was a longer trial, but unfortunately with the on-treatment analysis, the average time was actually 1 year. And I said, no, this would not be long enough to look for incident dementia. And when you looked at whether follow-up was complete, and if not, were reasons to follow up described and explored. So there was issues with the follow-up, and taken like the intention to treat analysis showed there were much longer times on treatment, but the on treatment analysis was much shorter, demonstrating that people were probably stopping treatment or switching treatments. And so loss to follow-up was not able to be really explored further. And were strategies to address incomplete follow-up utilized? Well, in this case, partially they did try to do some sensitivity analysis and see whether anything changed with that, but it was difficult to actually follow in this type of study. So conclusions were NOACs were associated with a lower risk of dementia versus VKAs, particularly for apixaban and edoxaban and other unspecified dementia. But there were significant methodological issues in the study, particularly how they looked at the outcome at this, even just baseline dementia at the start of the trial and the actual development of dementia. And in terms of implications for practice, I think it's too early to change a practice for anticoagulation prescribing, specifically for dementia risk. Further studies are needed, but NOACs are often preferred for other reasons, including the fact that they're easier to adhere to, lower bleeding risk in general. And so there might be an additional benefit to incident dementia, but we'll have to stay tuned for further studies. And I'd like to open it up for any questions.
Thank you very much, Gabby, for a beautiful presentation. And I echo Gary's last comment, a great presentation in the chat box. Barry as well. There are questions in the chat box, which I can summarize. Does anybody want to unmute to ask the question? In the interest of time, we really only have a limited number of questions that we can take. My one comment, Gabby, is it's interesting, despite all the adjustments, that there was a 6-year age difference in the cohort. So the NOAC patient population was 76 years old, or close to 76, whereas the VKA was 70 years old. And it's surprising that they had a lower risk of dementia simply based on age alone, let alone all the adjustments that were made. And so, Michael, I'll let you review that. And Michael, his hand is up. Go ahead.
Yeah, the real question I have, even if it isn't absolutely conclusive, I really question what's the place for warfarin in any condition now. It's been shown that it's not better for all the conditions for which we used to use it, other than if you want to bump off a political opponent, which of course it's used for in some countries. So can somebody tell me what they think warfarin's useful for these days?
Rodent control.
Yes. That's right. Rodent control or political adversary control.
Or mechanical heart valves.
Is that better than an OAC?
Yeah, I believe so. It's still used in the treatment of mechanical heart valves.
But there's at least one study that disputes that.
Well, okay, at least one, but there's some that confirm that. I mean, that's still to be that is still to be completely ascertained, but that's certainly my knowledge of it when it's used.
Thank you,
Irene
and Michael.
Can I ask one wee quick question?
Please.
And that is, the younger people do they pay for their drugs in Belgium, or are they free at the point of care? For instance, older adults here get the DOACs free, but not younger people, unless they have a.
That's a really good question. I actually had looked up, and I think that they do have prescription drug insurance, but I think it's a mixed private public model. So it would depend on, like, you might be funded through your private or public, but my understanding was there is funding for drugs. And that's why they have this, because they have this nationwide database where they can look at drug prescriptions for the entire country.
Well, we have that too.
Yes, similar, not too unsimilar for that.
And Gabby, I know you're pressed for time as well. I wonder if you have a chance to answer in the chat box Barry and Gary's questions. But for the sake of time, we will have to move on. So thank you again for the wonderful presentation. And we will welcome our next speaker, Dr. Peter Hoang, co-lead resident for this cycle, To further the discussion on this theme of anticoagulation in older adults with atrial fibrillation. Peter, please go ahead.
Thanks, Dr. Kentel. And you can see my slides, okay? Great. All right, so I'll be presenting on the differential effect of anticoagulation according to cognitive function and frailty in older adults with atrial fibrillation. And this study was published in the Journal of American Geriatric Society in February 2023. I have no conflicts of interest to disclose. For our objectives, we'll review the epidemiology of atrial fibrillation. We'll do a tour de trials, and then we'll undergo the study methodology and review its results, and finally, a critical appraisal. I'd first like to give the audience a moment to consider this scenario. You have an 85-year-old female living at home without dementia, with a diabetes and an A1C of 6.5%. Her CHA2DS2-VASc score is 4 for female age and diabetes, and her clinical frailty scale is 4 out of 9. Would you anticoagulate her? Consider the same scenario, except now you have an 85-year-old female living in long-term care, and her MOCA is 16 out of 30 with diabetes and an A1C of 7.8%. Her CHA2DS2-VASc score is the same, but her clinical frailty scale is higher. Would you anticoagulate in this scenario? As this audience is well aware of, atrial fibrillation is very common, and its incidence continues to increase. Over the last 50 years, the Framingham Heart Study has shown that the prevalence of AF has tripled. The current estimated lifetime prevalence is 1 in 4, and an overall prevalence of 1 to 2%. Some of this is related to enhanced detection, which is particularly important given many individuals with AF are asymptomatic. However, it still likely remains underdetected. We are all very aware of the risk factors associated with AF, perhaps the most important one being age itself. Some of the others as listed include race, ethnicity, and potentially modifiable risk factors such as hypertension, diabetes, obesity, and smoking. Atrial fibrillation is associated, just move on. So atrial fibrillation, as this audience is well aware of, is associated with increased mortality. But while patients do not usually die from their arrhythmia, they're at increased risk of heart failure, myocardial infarction, as well as, of course, stroke. And the risk of those outcomes are shown in this slide. Individuals who carry comorbidities based on the CHA2DS2-VASc score have an increased risk of stroke relative to the number of comorbidities. And to put this in perspective, the annual risk of stroke in an 85-year-old individual with a CHA2DS2-VASc score of 4 is about 5%. And this is not insignificant considering its morbidity. So given a disease so common and morbidity and mortality associated with these negative outcomes, many landmark trials have been undertaken. And I took the opportunity during this journal club to summarize these studies or the tour de trials. And no biking will be required, and I hope no arrhythmias occur as I go through them. Next slide, please. The first study to be published, to my knowledge, is the Stroke Prevention in Non-Rheumatic Atrial Fibrillation, or SPINAF. This study came out in 1992. This randomized controlled trial included 525 male veterans with a mean age of 67 and diagnosed AF not on any anticoagulation. They were excluded based on antiplatelet use, anticoagulation contraindications, or TIA/stroke. Individuals were randomized to warfarin or placebo to target an INR of 1.4 to 2.8 over a 3-year study. As shown in the next slide, there was a significant reduction in stroke, but not all-cause mortality. For stroke, the risk reduction was 0.79. There was only one cerebral hemorrhage event in the warfarin group. For all-cause mortality, it did not reach statistical significance. As such, my bottom line for this article was that warfarin reduces stroke. However, how does this compare to aspirin? Next slide, please. The next major study to come out was SPAF2, or Stroke Prevention in Atrial Fibrillation 2 study. This was published in 1994. 715 individuals were included, where group 1 were those under the age of 75 and group 2 above. Their mean ages were 64 and 80 respectively. Individuals had to have non-valvular AF for at least 12 months, and they were excluded if they had a stroke or non-valvular AF. Warfarin targeting an INR of 2.0 to 4.5 was compared to ASA 325 over 4 years. Next slide, please. Compared to aspirin, the risk reduction was all smaller for ischemic or all strokes, but these did not reach statistical significance. Those risk reductions were 0.7 for ischemic stroke and 0.88 for all strokes, respectively. And once again, there's no difference in mortality. For major hemorrhage of note, those over the age of 75, there was a significant difference in bleeding, with more major hemorrhage in the warfarin group. As such, my bottom line was that warfarin may be slightly better than ASA, but are we sure? Next slide, please. The next study was BAFTA, Birmingham Atrial Fibrillation Treatment of the Age Study, and it was published in 2007. There were 973 participants with a mean age of 81. Similarly, individuals were included if they were equal or over the age of 75, with AF documented within the last 2 years. They were excluded based on rheumatic heart disease, a history of intracranial hemorrhage, or a contraindication to warfarin. The intervention was targeting an INR of 2 to 3 over a mean of 2.7 years compared to ASA 75. For the primary outcome of stroke, warfarin was superior with a risk reduction of 0.30. This is similar for all strokes with a risk reduction of 0.46. And as seen in the trend of these studies, there was no difference in mortality. However, of importance, major hemorrhage was not different. There are a few other studies that were published during this period that I did not have the chance to present today. Regardless, my bottom line for this article is that warfarin is superior to ASA. However, is there anything to reduce bleeding risk and anything that requires less monitoring? So the next slide initially had a meme that I was going to show when I was in 2013. But if I may share for a second, I can at least just show the slide without that meme for the next landmark trials that came out were between 2009 and 2013. And those were RELY, Rocket AF, Aristotle, and Engage. And as you can see in these on the asterisks, all of them showed a significant reduction in ischemic stroke and embolism compared to warfarin. And the same, if not better, for major bleeding, particularly for apixaban and edoxaban. The only study that showed a difference in mortality was apixaban. Regardless, now we know that DOACs are better. I was hard-pressed to find post-marketing studies that were able to show me that of all of the anticoagulant therapies. But this has completely changed the practice of atrial fibrillation and has changed how patients are managed and improve their outcomes. So the CCS guidelines came, the most recent update in 2020, and instead of using the CHADS-VAST, they've opted for a simpler algorithm using CHAD65, where anyone over the age of 65, a prior stroke, TIA, hypertension, heart failure, or diabetes are indicated for oral anticoagulation. And they also make a statement on frailty and cognitive impairment. And their statement is strong. They're given their evidence that age did not make a difference for those for atrial fibrillation. They recommend for all individuals over the age of 65 and to consider frailty and cognitive impairment, but still treat. That being said, there are differences in practices for the use of anticoagulation. Prior to studies of the NOAC therapies in individuals who are living in nursing home, under 50% with those who were indicated for warfarin at that time were actually being treated. And there are inherent changes in practice in individuals living in long-term care. Generally speaking, all of those individuals are not being treated with oral anticoagulation. One study by Zhang et al. In 2021 showed that for individuals with geriatric syndromes, including falls, moderate to severe ADL impairment, or moderate to severe cognitive impairment, they were less likely to be treated with oral anticoagulation. And in their cohort, 20% of them were not receiving, despite being indicated. There are conceptual reasons why frailty and cognitive impairment may play a role in the reduction use of oral anticoagulation. As an individual ages, there are changes to the balance of hemostasis, and this generally is a trend towards thrombophilia. Individuals have changes to their vasculature, they're generally more sedentary, and they have a likelihood towards thrombosis. That being said, because of the frequent prescriptions of antiplatelets and anticoagulants, they're generally more likely to bleed. As we know, those who have changes in brain atrophy are more likely to be associated with subdural hemorrhage. And this is particularly related in the context of falls and injury. As such, the objective of this study was to ask, in older adults with atrial fibrillation, are cognition and frailty status associated with greater harms while on anticoagulation? Participants from this study came from the SAGE-AF study, which are 6 ambulatory settings where individuals had to have a diagnosis of atrial fibrillation, were age over 65, and had a CHA2DS2-VASc of at least 2. The exclusion criteria are shown in this slide. Notably, an inability to consent or inability to follow up were reasons for exclusion. They're all followed for 2 years, and the exposure is anticoagulation. 2 things were used, as mentioned, frailty as well as cognitive impairment. For frailty, they used the Fried Frailty Scale, which measures 5 things: unintentional weight loss, weakness or poor hand grip strength, self-reported exhaustion, slow walking speed, and low physical activity. Scores of 0 mean no frailty, 1 to 2 being pre-frail, and 3 or more being frail. For cognitive impairment, they used a MoCA score under 23. To provide a background and context to why this was used, they cited a study that they had published in 2015, where an MMSE score was previously used for MCI and that for 27, and that was correlated to a MoCA of 23. We now know that MMSEs generally are not used for MCI. I took this to interpret such that we now have a greater discrimination, at least, by using a lower MoCA score, potentially. The primary outcome was major bleeding or death, and secondary outcomes were death, major bleeding, clinically relevant bleeding, or composite of death, bleeding, and stroke. For a statistical analysis, the baseline characteristics were compared using chi-square tests, ANOVA, and t-tests, and propensity score was used for those receiving anticoagulation. As mentioned in Gabby's presentation, this is a method to match participants so they're as equal as possible. These were matched based on clinical significance as well as statistical significance, and some of those are mentioned here. The relevant ones including age, CHA2DS2-VASc, has bled, the type of atrial fibrillation, their history of stroke, as well as their eGFR. Cox regression analysis was used to develop hazard ratios adjusted by the propensity score, and these were stratified by cognitive impairment and frailty. So we now go into our baseline characteristics of and the results of the study. Of just over 6,500 individuals that were screened, 4,400 were eligible, and 1,200 enrolled. Of those not enrolled, half of the time was because they were not interested, or as said maybe, and would attend the next visit, and it still ended up not being enrolled. I'd like to give the audience a moment to absorb this information for the participants. The average participant was 75, male or female. They had a CHA2DS2-VASc score of 4.4, a HADS-BLEDS of 3.2. They were generally on anticoagulation, and half of them were on warfarin. The typical patient's MoCA was 24. They were not frail, although they had 20% had falls in the last 6 months. 10% had a stroke, and 8% had major bleeding. As we go through the baseline characteristics, these are divided based on their anticoagulant use. And compared to those who were not on anticoagulant, those on anticoagulant were likely to be younger, to have a lower CHA2DS2-VASc score, and to have paroxysmal as opposed to permanent atrial fibrillation or long-standing atrial fibrillation. The supplementary of the study also included warfarin and DOAC compared to no anticoagulation. And of note, those who were on warfarin were likely to be older, to have a higher CHA2DS2-VASc score, and to have more persistent atrial fibrillation and a lower eGFR, except that eGFR is not low enough to be contraindicated to a NOAC. 42% of individuals had cognitive impairment in this study. And this study showed that there was a higher risk of major bleeding or death while on anticoagulation in those with dementia. For those with dementia, the hazard ratio was 2.23, and for no dementia, the hazard ratio was 0.94. This is shown in the Cox regression, shown on the right-hand side. And as you can see, these curves separate quickly. In those with cognitive impairment, anticoagulation was associated with more clinically relevant bleeding and the composite outcome of bleeding or death. And this, again, these are the Cox regression analysis, and as shown for those hazard ratios in the blue, those are the ones that are significant. And the interaction between cognitive impairment, anticoagulation, as well as major bleeding or death was significant. The same thing was done to frailty. 13% of individuals were frail, and there was no difference between anticoagulation and frailty status on the outcomes. Once again, similarly on the right-hand side, all of these lines cross each other and cross one. There might be something interesting about the stroke outcome for such a wide confidence interval, but it's hard to know based on a small sample size. Of note, their incidence of stroke in the 2-year study was only 1% each year, so very small. There was no difference between DOAC and warfarin for bleeding and death. And those hazard ratios are shown here for no frailty and frailty respectively, and both of those crossing one. And maybe there was a difference between DOAC and warfarin for bleeding and death. So these were DOAC and warfarin were compared to one another. And in cognitive impairment, that was not significant, but in no cognitive impairment, DOAC and warfarin are on the borderline of being different from each other. To put this into clinical relevance, the numbers needed to treat were also considered and calculated for the study. So the overall number needed to treat for stroke prevention was 30 to 45. And to put into perspective, if I recall correctly, the number needed to treat for stroke in all comers was about 25 in all individuals. And I'd like to give the audience a moment to compare these number needed to harm and number needed to treat. As you can see, in those with who were cognitively impaired and those who were frail, those numbers are generally smaller than those who do not have cognitive impairment or do not have frailty. I've highlighted some other outcomes here. For clinically relevant bleeding or death, only 5 individuals in their cohort had to be on anticoagulation before one would suffer this harm. On the other hand, in those who had no cognitive impairment, 842 needed to be treated, or sorry, needed to be on anticoagulation before a major bleeding episode. Again, to put into perspective, the number needed to harm for all comers for major bleeding and death was about 60 to 100 in the analysis of all of the DOAC trials. So now we go into our critical appraisal. Were the two groups similar and recruited from the same population? I gave this a yes. The SAGE-AF is a very well-known study that started in 2015 or so. And all of these individuals were ambulatory, and they have to have the same diagnosis of atrial fibrillation and the CHA2DS2-VASc of at least 2. Was the exposure measured in a valid and reliable way? The exposure in this study was anticoagulation, and they used 2 measures to capture that. The first one was participant report, and the second one being assessment of EMR records or administrative database to ensure that they were filling their anticoagulation. Of note, in the inception study of SAGE-AF, they did measure adherence, and this was noted in the supplementary as well. Although they didn't report the use of DOAC in terms of its adherence, about 40% of the time, individuals were either being underdosed or overdosed. And similarly for warfarin, about 40% of the time, individuals were not in the therapeutic range. Regardless, I thought this was using at least 2 measures of anticoagulation was an adequate way of trying to measure issues in adherence and use of medications in an outpatient setting. For the third, question 3, were the outcomes measured in a valid and reliable way? It comes to no question that for the outcome of death, those are measured very reliably. And for those with bleeding and stroke, what they used was the International Society of Thrombosis scale. And I'm sure you're all aware, it essentially accounts for comprehensively any changes, any outcomes related to bleeding, a loss of hemoglobin, or the requirement for transfusion. And these were measured using their administrative databases and their chart review. And as such, I gave this a check mark. Before we go to the other components of the Joanna Briggs Institute scale, I wish the audience to consider a few scenarios. In this specific study, they used anticoagulation where they combined DOAC and warfarin versus no anticoagulation, and they considered frailty and cognitive impairment as effect modifiers on the outcomes of bleeding, death, or stroke. Effect modifiers are essentially a variable that changes the effect of another variable upon stratification. So the best way, a good example of this is a drug that has an effect in females but not males. So upon making a strata of sex, there's a difference in of one variable on another. And in this case, it was frailty and cognitive impairment on the outcome. And they state that there was, in those with cognitive impairment, that there was, that they actually did worse, but they didn't separate DOAC and warfarin. Wouldn't this study be interesting if they compared DOAC versus no anticoagulation and warfarin versus no anticoagulation? We just had a discussion earlier that almost all individuals should be on DOAC nowadays, given the known studies of its safety profile. What if this study had separated that and shown that those who are on warfarin and cognitive impairment actually had worse outcomes? Would that change your practice? Consider another scenario where instead of dichotomizing the outcome of cognitive impairment and no cognitive impairment, or frailty and no frailty, we used multi-level modeling, and we considered them on a continuous outcome for the degree of cognitive impairment or the degree of frailty, and we separated by anticoagulation and no anticoagulation. It'd be interesting if as cognitive impairment or frailty worsened, you reached some point where individuals will start to have more major bleeding or death. What if that MoCA score was about 15, where individuals started to have more bleeding and death? Would that change your practice? Shown another way, consider this Cox proportional hazard, hypothetical situation, where individuals were separated based on the type of cognitive impairment, the frailty category, or the severity of cognitive impairment. Where the dotted line shows no anticoagulation, what if mild cognitive impairment or mild frailty on anticoagulation was not really different, very similar to the post-marketing studies? And what if as cognitive impairment became severe, those who are on anticoagulation separated off very quickly? Would that change your practice? And finally, consider this last scenario, where in enrollment of these individuals for the SAGE-AF study, they were either on anticoagulation or not on anticoagulation and had atrial fibrillation. They were then enrolled in 2016 to 2018, and they could have been on anticoagulation for any amount of time and could have had atrial fibrillation for any amount of time. Consider a cognitively impaired individual who was not on anticoagulation and died before study enrollment. Wouldn't it be interesting if the strongest survivors not on anticoagulation were the ones who were enrolled in this study? Would it not appear as though anticoagulation is actually worse because you're comparing to the strongest survivors? In those four scenarios, we considered four sources of bias. For the first, we wondered if there was an unmeasured effect modifier. For the second, we wondered if a continuous outcome might be more appropriate. Perhaps a MoCA of 23 and 24 are not very different, except in this study, one was cognitive impairment and the other was not. Perhaps this study can be confounded based on the severity of the disease or the subtype of the disease. And finally, we considered the issue of bias based on the time of entry to a cohort study. So with that, I go back to components of the Joanna Briggs Institute, where confounding factors identified. I gave these scenarios for the audience to consider. Is this population similar enough to my population that I would be comfortable with anticoagulation or no anticoagulation? And similarly, were strategies used to deal with confounding factors stated? I think there is a great opportunity for other analytic methods to have been considered in this study. But I recognize that some of these questions some of these studies always lead to more questions. And finally, was this appropriate statistical analysis used? I think overall, propensity score matching and the Cox regression, I think those are very appropriate to answer the specific question. But there are, again, always more. So in summary, this was a generally low frailty mild dementia cohort. And anticoagulation was associated with greater risk of death or major bleeding in those who had cognitive impairment. And while frail individuals had more bleeding, this was not statistically significant between the outcome of anticoagulation, frailty, and the composite outcome of major bleeding and death. So for my bottom line, older adults with cognitive impairment may be less likely to experience benefit from anticoagulation and greater risk of harm. Shared decision-making remains imperative and further studies are needed. And I end with a Carolyn-approved pun. Will you be giving sage advice for anticoagulation in atrial fibrillation? Thank you.
Thank you very much, Peter. What a fabulous presentation and maintaining your calm through some technical difficulties. And I echo a lot of the comments in the chat. Barry Goldlist writes, fabulous discussion, exclamation mark. Christina has also says, awesome presentation. Gary as well, great presentation. Christina writes, I have some issues with the quality of the propensity score analysis here. Was there a table showing acceptable balance and baseline covariates between treated and non-treated subjects after applying the propensity score? Did they address balance at all? I only see one table, table 1 with p-values, not appropriate for descriptive purposes.
Yes, so my very limited understanding of propensity scoring is that at some point there should be a table of comparing these individuals to ensure that they are matched. I unfortunately did this without my script. So I did not see the type of propensity score matching, and in the supplementary, I could not find this specific table ensuring that they are matched. And as we can see, the warfarin individuals are different from those who are on DOAC. And particularly at EGFR extremes or BMI extremes, the type of propensity matching should be considered heavily.
Great, thank you. Barry, hand is up. Go ahead, Barry.
I just wanted to compliment Peter on bringing up what I think one of the most important issues, particularly in frailty. We have thousands of articles showing that frailty is bad for any outcome. None of them have put it in a way I would say would operationalize it. For a primary care physician, what degree of frailty would suggest that you shouldn't go ahead with this type of therapy or intervention? And so that we've got all these studies that really don't help primary care physicians in making decisions for their elderly patients. So I'm thankful that you highlighted that for this particular study, but I think it goes way beyond just this study. Thank you, Peter.
Thanks, Barry. Irene mentions, really enjoyed both presentations, great explanations of propensity scoring. And Peter, go ahead if you want to articulate what you've written.
Oh, that's actually not me. I sent a link to the WhatsApp group to ensure all the residents had the link. And it's, so there's 2 meetings.
I see. So another, Peter Wang, number 2, I agree with Christina RE, the propensity scoring. Also, it's interesting that they matched and not in inverse propensity scoring weighting, which is more heavily favored nowadays as more effective at balancing. So thank you for that insight. Gary has his hand up. Go ahead.
Thanks, Peter. Really enjoyed the presentation and your thoughtfulness. I was trying, I may be overthinking it. I was trying to, I guess, understand the results and wondering a bit about some of the consequences of being cognitively impaired and how that could influence the outcomes. For example, are people with cognitive impairment not at increased risk of mortality compared to people without, whether they're on anticoagulants or not, and can that influence the outcome? And the other thing is, could having cognitive impairment, in terms of what may explain some of the, like people with cognitive impairment, does that affect their adherence in a significant way? Are they taking too many tablets some days, maybe not enough the others, and might that be influencing the risk of bleeding? And the reason I was trying to think about this is some people may conclude from this is don't use anticoagulants in older people with cognitive impairment with atrial fib, as opposed to we need to perhaps focus more on adherence issues to make sure that the drugs are being taken properly to protect them from the stroke events, which would be worse for their cognitive impairment, and you want to prevent, but might prevent them from having bleeds from perhaps taking too many tablets on different days. So I was just trying to think about how to interpret these results and what the takeaway is.
Yeah, I agree entirely. I think on the basis of dichotomizing cognitive impairment and no cognitive impairment, it's very hard to draw conclusions. Like there's so much context. And we know that individuals with cognitive impairment are at increased age alone, the changes, their comorbidities, all of those things increase your risk of mortality as does. So yeah, I think there are a lot of confounding factors that need to be, must be interpreted carefully in the context of this article.
Thank you for that. And in the chat box, Christina adds another methodological concern. Christina, do you want to unmute and articulate it, or shall I read it?
I'm sorry, I feel like I'm getting into the weeds here. I just felt that the description of the methods left a bit to be desired related to what they actually did with the propensity score. But anyways, great job, Peter, explaining it.
Yeah, no, I think, thanks, Christina. I think that's appreciated by the residents, the comments on the method. So thank you. And thank you, Gary. As we approach the top of the hour, thank you to both our residents today for excellent presentations. As always, continue to set the bar higher and higher. Also want to thank Barb for her efficient troubleshooting with the technical difficulties earlier. The evaluation link should have been sent to your email inbox moments ago. And thank you all for joining this morning. We will see you next month.